Thoracic outlet syndrome is the name given to a group of neurovascular compression syndromes that occur, as the name implies, in the thoracic region where it outlets into the upper extremity. We'll be demonstrating everything in this webinar on the right side for consistency of view for you folks there. The four types of thoracic outlet syndrome are anterior scalene syndrome in the anterolateral neck, costoclavicular syndrome over here between the clavicle and first rib, pectoralis minor syndrome between the pectoralis minor and the rib cage, and the fourth type is called cervical rib thoracic outlet syndrome, wherein there's a genetic anomaly called a cervical rib. All four cases of thoracic outlet syndrome will exhibit the same types of signs and symptoms. And a quick note on that. A symptom is subjective in that it's something that the client feels. Another person can never tell a client that they do or don't feel something. Something like pain is subjective, is a symptom. Whereas a sign is an objective measurement that a therapist can measure, something like taking the strength of someone's pulse or the temperature of someone. So we will have both signs and symptoms possibly with thoracic outlet syndrome, and they will generally be in the upper extremity. Because if we're having neurovascular compression of neural and vascular structures in this region that go down to the upper extremity, we expect that the symptoms would play out in that upper extremity. The term neurovascular implies neural, which means nerves, neuron cells, nerve cells of nerves, and vascular implies arteries and veins. So if we look at the type of signs and symptoms we would have with neurovascular compression, it would make sense if we just look at the mechanics. A peripheral nerve is a north-south two-lane highway. There is northbound neurons going toward the central nervous system, bringing sensory information from the periphery, in the case of thoracic outlet syndrome, the upper extremity, into the spinal cord, cervical spinal cord, central nervous system, to tell us what we feel. If we are compressing on sensory neurons, we would have altered sensation. In other words, paresthesia. Something like pain, tingling, numbness. If instead the compression is on the southbound lane going from the central nervous system down into the upper extremity, then we are compressing on motor neurons. Now, motor neurons run down into the body in the peripheral nerves to instruct muscles to contract. If we compress on a motor neuron within a peripheral nerve, then we might irritate that motor neuron and cause contractions, involuntary contractions, to occur in the muscle fibers, the muscle cells that are controlled by that motor neuron synapses with in that motor unit. And we might end up with, in lay terms, twitching, or in fancier terms, fasciculations, involuntary small contractions of the musculature. If instead the compression on the motor neurons is so strong that it actually blocks entirely the axonal flow of information in the motor neuron, then the motor neuron would be unable to bring its signal down to tell its muscle fibers to contract, and we might end up with weakness in that musculature. And if it's long-standing, those muscle fibers innervated by that motor neuron, if they do not get fed in effect by the motor neuron, might actually in time die, and we could have atrophy in the musculature. So neural compression can cause both sensory paresthesia, altered sensation, as well as motor dysfunction, twitching fasciculations, or weakness, perhaps atrophy. If instead we have an artery that's compressed, the role of an artery is to deliver oxygenated blood filled with nutrients beyond oxygen, other nutrients, down into the body area where that artery goes. Again, here, we're looking at the right upper extremity. So if we were to compress that artery and we decrease the arterial flow, we would have something called ischemia. Now, ischemia means that we're not going to have as much oxygen in that upper limb as we should. And if the client has a light pallid skin, instead of seeing what we might describe as a rubor, a slight reddishness to the skin color, they would actually become either cyanotic, a little more bluish, or perhaps even whitish. So ischemia would show with a pallor change in the upper extremity, again, if they have a light complexion skin. A dark complexion skin client, you probably would not be able to judge that. If we have venous obstruction, so there's compression on the vein that is coming from the upper extremity, feeding venous blood back toward the heart, coming up through here, then we would block return of fluid from the upper extremity, and we would have congestion in the upper extremity, in other words, swelling. So we might see swelling in the upper extremity, especially the distal upper extremity around the wrist hand area. So vascular compression can be arterial compression or venous compression. Arterial compression would show perhaps as ischemic cyanotic coloring. Venous congestion might show as congestion, swelling in the upper extremity. Neurovascular compression. Most of the time with thoracic outlet syndrome, if we take 100 cases, 90 of them will manifest with neural compression, signs and symptoms, approximately 9% with arterial compression, and 1% with venous compression. And certainly it's possible to have a mixture of neural compression, arterial compression, and venous compression. The 4 different types of thoracic outlet syndrome, as we mentioned before, are anterior scalene syndrome, costoclavicular syndrome, pectoralis minor syndrome, and something called cervical rib thoracic outlet syndrome. Let's take a slightly more detailed look at each one of these. Whenever we're confronted with a new term in the world of manual and movement therapy, kinesiology, it's always beneficial to first look at the term, look at the word, and see if it gives us information. So, anterior scalene syndrome is a condition wherein we have neurovascular compression between the anterior scalene muscle and the middle scalene muscle. The anterior and middle scalene muscles attach onto the transverse processes of the cervical vertebrae, and from there run down inferiorly and a bit laterally to attach onto the first rib. In any way, if we overly facilitate, if we overly use, if we use these muscles too much and they get locked short, tight, even locked long, tight, but if they get tight, they get harder. If they get harder, then if there's anything running between them, then that structure running between them would be compressed like a piece of meat in sandwich bread. And between the anterior and middle scalene muscles, we have the neural structures of the brachial plexus, and we have the subclavian artery. Now, the neural structures of the brachial plexus begin as the nerve roots C5, C6, C7, C8, and T1. Those nerve roots exit out through the intervertebral foramina, the IVFs of the cervical spine, and then they combine together into trunks. The trunks then divide out into divisions, then transition into cords, and then end as branches. Now, when we have compression, neural compression between the anterior and middle scalene muscles, it's either going to be the nerve roots and or the trunks. And again, neural compression can cause either sensory, altered sensation, paresthesia, or motor dysfunction. We also have the subclavian artery running between the anterior and middle scalene muscles, and if the artery is compressed, we could have ischemia into the upper extremity, as we have stated before. Why might we have tight anterior and middle scalenes? Well, the scalenes are involved with moving the cervical spine. So a postural overuse or a movement overuse of the cervical spine might create that scenario, and we'll talk about that in more detail in a few moments. They also lift up on the first rib, which is involved with breathing. So a chronic obstructive breathing disorder might also play into anterior scalene syndrome. Costoclavicular syndrome. Again, we look at the term. Costo means rib. Clavicular implies the clavicle. So there is a space between the first rib and the clavicle right over in here called the costoclavicular space. The brachial plexus neural structures run through that space. The subclavian artery runs through it, and the subclavian vein. If we have neural compression, we would get the neural symptoms. If we have vascular compression, arterial, we would get ischemia. Venous, we would get congestion, swelling. Why might we have a problem in this costoclavicular space? Well, one reason is that maybe the clavicle collapses down onto the first rib and diminishes the size of the space. Another is perhaps the first rib lifts up against the clavicle and diminishes the size of the space. So we would be looking at postural dysfunctions that might cause that type of scenario or those types of scenarios. And again, in a moment, we'll look at that in more detail. Pec minor syndrome, again, we're expecting there to be an issue with the pectoralis minor muscle. The pectoralis minor runs from the coracoid process of the scapula, usually to ribs 3, 4, and 5. If the pectoralis minor were to get tight, well, we have the brachial plexus neural structures running between the pec minor and rib cage. We have, at this point, it's no longer called the subclavian artery. Now it's the axillary artery running between, and we have the axillary vein. So we could have neural compression, neural symptoms, arterial compression, ischemia, venous compression, congestion, swelling. Again, we're always looking at symptoms in the upper extremity. Why might the pectoralis minor get tight? Well, in some way, we either overuse the pec minor, maybe someone who is doing excessive exercise, working out in front, building up the pectoralis tissue. It gets hypertrophied, thicker and tighter, and then it compresses these structures against the rib cage. Or perhaps it's due to an adaptive shortening with a postural dysfunction, and again, we're going to get to that in a moment. So we would have our pectoralis minor syndrome here. Now we have the fourth type, cervical rib thoracic outlet syndrome. Now a note on this name. Sometimes cervical rib thoracic outlet syndrome, especially in the medical world, is called true thoracic outlet syndrome. Now I will state I do not like that term being applied because in some way that implies that the other thoracic outlet syndromes are false, which is not true in any way. Any neurovascular compression, whether it's by a bone, a cervical rib, or tight musculature or postural dysfunction, is still neurovascular compression and can cause the symptoms and signs that we might find with thoracic outlet syndrome. The reason that term is often applied in the medical world is that medical physicians, therapists, professionals generally do not pay attention to myofascial, periarticular, extraarticular soft tissue. They tend to diagnose from an X-ray years ago when these names were applied. And an X-ray would never show a tight pec minor or tight scalenes, and an X-ray might show the postural change of the positioning of clavicle and first rib, but again, they probably would not really have paid much attention to that. And even today, with MRIs, MRIs do show soft tissues, but they don't show functional changes in soft tissues. You don't see a tight muscle one way versus a loose muscle on an MRI. And even if it did, even if it were to show that, the odds are that medical professionals would not really pay attention to that much. That's not the way their ideology tends to go. We, as manual therapists, movement professionals, we tend to look very much at myofascial tissue and the dysfunctions, postural and movement dysfunctions that might occur and what could occur as a result of that. So to me, all types of thoracic outlet syndrome are true thoracic outlet syndrome. Now, to return to cervical rib thoracic outlet syndrome. We normally have 12 pairs of ribs, and they come off of the thoracic vertebrae. And in fact, that is what defines the thoracic spine as the thoracic spine. But there can be a genetic anomaly. It occurs in approximately 1 to 2% of the population, wherein a rib starts to come off from C7. And that would then be called a cervical rib. Now, sometimes that cervical rib is just a very, very small little piece of bone that by definition is a cervical rib, but it's so small that it is irrelevant. It's an incidental finding. But sometimes that cervical rib can become much larger, much longer, and start to wrap around toward the front, like ribs do. And if you have a cervical rib off C7 that wraps toward the front, it can come right between the anterior and middle scalenes and cause compression just like anterior scalene syndrome would, which would mean neural compression on brachial plexus structures and arterial compression on the subclavian artery. We will look at the assessment of all 4 types of thoracic outlet syndrome in just a moment from the point of view of orthopedic assessment and palpation assessment where relevant. But before we do that, I'd like to spend a few minutes looking at some of the real underlying causes mechanically that can lead us to have a client that has thoracic outlet syndrome. Now let's take a closer look at the mechanics, the pathomechanics that can lead a client to develop thoracic outlet syndrome. I'm going to discuss a postural dysfunction that is usually the major reason why for all 3 types that are myofascially concerned. But before we do, let's just mention that with anterior scalene syndrome, as was stated before, the scalenes are involved with breathing because the anterior and middle scalenes attach onto rib 1, and from there they attach more superiorly onto the cervical spine. That means that they can lift rib 1 up. And lifting the rib cage up is generally associated with breathing in, with inspiration. Now that means that if someone has some type of labored breathing, very often this is described as COPD, chronic obstructive pulmonary disorder. It could be emphysema, it could be asthma, it could be chronic bronchitis. For whatever reason, the person is laboring to breathe and they are recruiting accessory muscles of respiration, but specifically accessory muscles of inspiration, including the scalenes, then the scalenes might end up getting tighter. Because when we engage musculature more, it does tend to get stronger, but it also tends to get tighter at baseline tone. And again, if it gets tighter, it gets harder. And if it gets harder, it's more likely that we will have a compression with the neural and vascular structures that are located between the anterior and middle scalenes. So one major reason for anterior scalene syndrome is labored breathing. But now let's look at a postural dysfunction syndrome known as upper crossed syndrome, which was named by Vladimir Janda. Upper crossed syndrome involves a number of components from the thoracic spine upward. And we're going to break them down first a bit artificially into pieces. So we have our client, our model, London here. And London, what I'd like you to do is first show the rounding of the trunk, the rounding of the thoracic spine. Hyperkyphosis, too much flexion of the thoracic spine. Then we have the lower and middle cervical spine starting on the superior border of T1's body, which means the lower cervical spine is now starting on a more vertical surface and it's now projecting more anteriorly. It's following that thoracic kyphotic curve of flexion, which means that the lower and middle cervical spine has less extension, it has more flexion. It's hypolordotic. And then, because when you go out this way in this direction, her eyes are looking downward and she cannot process the world, see where she's going, she would have to compensate for that with hyperextension of the head upon the atlas at the atlanto-occipital joint. And by the way, we can then see that we have forward head carriage. The center of weight of the head is over thin air, which we can also talk about, well, what does that mean for the musculature here? Well, if the center of weight of the head is over thin air, she should fall into flexion. If she doesn't, with gravity bringing her chin to chest flexion, that means that there must be a force of extension that is working to balance that out. That means the cervical cranial extensors, the posterior extensor musculature in the back of the neck to head must be constantly isometrically engaging to hold what would otherwise be an imbalanced posture. So now we're looking at tight muscles back here. If these muscles get tight, that can play into tension headaches. It can actually even create problems pulling on the mandible with some of the tightness in front, and that can cause TMJ, temporomandibular joint disorder syndrome. So we have a whole number of factors in the axial spine skeleton here. We also have that the shoulder girdles, the scapula and clavicles will protract forward here, and the arms, the humeri at the shoulder, glenohumeral joints, will medially internally rotate. So there's a complex constellation of factors that are involved in upper crossed syndrome. Now come back for a moment, be in a nice healthy posture. Now, can you do all of that again as best you can? Go ahead and I'll help you if necessary. And we can see this postural dysfunction pattern compared to, go back to healthy. Now, just a note on this. Most of what we do is down in front of us, especially in civilized, Western world industrial society. And this was true 30 years ago before digital devices. We would write down on a piece of paper, we would read down here, etc. But with the proliferation of smartphones and tablets and laptop computers, etc., we are spending so many more hours down like this here that we are accelerating the pace of the upper cross syndrome occurring in our society. And this is true, I said before, Western, this is true throughout the world, I believe. So we are seeing more and more upper cross syndrome, and as we'll relate it in just a moment, therefore, more and more thoracic outlet syndrome. Okay, now let's have an anterior view, so I can have you face the camera here, right there. So if we look at the sequelae, the effects of this posture, this postural dysfunction, upper cross syndrome, let's take it one at a time. We have the hyperkyphosis of thoracic spine leading to hypolordosis of the lower and middle cervical spine. Hypolordosis of the lower and middle cervical spine means that there's too much flexion. That means that all muscles of flexion in the front of the neck will be shortened. If we keep them shortened for prolonged periods of time, they will adaptively shorten and they will become locked short, overly facilitated, tight at baseline tone, harder, and they can compress the neural vascular contents between them. So this posture for the cervical spine can lead to anterior scalene syndrome. Okay, come on back. Now, let's look at costoclavicular syndrome, the costoclavicular space between the first rib and the clavicle. I'd like you to go into that posture again, right there, and even protract, and the shoulder girdles protract forward, even collapse down some. Now what we have is the clavicle collapses down against the first rib, making that costoclavicular space smaller, increasing the likelihood of neurovascular compression there. So upper cross syndrome also predisposes toward costoclavicular syndrome. Come on back. Pec minor syndrome. Well, pec minor syndrome is caused by a tight pectoralis minor. Let's go one more time. Hyperkyphosis thoracic spine, the entire cervical spine head, but shoulder girdles go forward, drop down, and by the way, there's also an aspect of downward rotation of the scapula. Well, the pectoralis minor is a protractor, a downward rotator and a depressor of the scapula. So if we allow it to be in this shortened position, the position passively perhaps, but the position of its joint actions, its concentric shortening joint actions, it will be shortened. And if we stay this way for a prolonged period of time, we will adaptively shorten and the muscle will get tighter, overly facilitated, locked short, harder, and more likely compress the neurovascular contents between the pec minor and the thoracic wall, the rib cage. Come on, back up. So we can see that upper crust syndrome, dysfunctional postural pattern, is very often the underlying mechanical cause for anterior scalene syndrome, costoclavicular syndrome, and pectoralis minor syndrome. And for this reason, it's very common when a client has one of these thoracic outlet syndromes for the client to have a second or perhaps all three, whether it's unilaterally or bilaterally on both sides. Now let's look at orthopedic assessment for the various thoracic outlet syndromes. We will use something called Adson's test for anterior scalene syndrome, Eden's test, also known as military brace position, for costoclavicular syndrome, and Wright's test, and there will be two versions of Wright's test, for pectoralis minor syndrome. Mechanically underlying what we're looking at here fundamentally is the same idea in each case. I am going to be finding the client's radial pulse. I need to get a baseline there. If you've never felt for a pulse, usually what you want to do is not use your thumb, but use your pads of your index and middle fingers. Radial pulse is usually easier to find than ulnar pulse, but you could use ulnar pulse. And you just place it lightly, and the client needs to be relaxed, and you need to feel for the pulse. And what we are feeling for is the strength of the pulse, not the rate of the pulse, the strength of the pulse. That's very important. And the idea behind this is very simple. The subclavian artery, which becomes the axillary artery, which becomes the brachial artery, which splits to become the radial and ulnar arteries, is bringing blood from the heart. And each time the left ventricle contracts and sends blood through the aorta to get to here, we feel that systolic pressure there, and we feel what we call the pulse. And the strength of the pulse lets us know the packet of blood, so to speak, that's coming through the artery down here. If there is a compression of the artery anywhere in this thoracic outlet region, then it's kind of like putting your foot on a garden hose and lessening the water coming through the hose. Now, with this analogy, I need to say something. When you have water coming through a garden hose, if you press on it, there's nowhere else for the water to go except through that hose. So actually, the water comes through faster. But in the arterial system, there are other arteries that when you compress at subclavian or axillary level, the blood could shunt through the other arteries, so we will end up with a weaker pulse. If we have a weaker pulse that we register down here, we palpate down here at the radial artery, then we know that there is compression somewhere along the arterial pathway. Now, if we take a close look at the anatomy, we will see that the artery, the vein, and the brachial plexus neural structures run within one fascial sheath. And they are very close to one another, especially as we get toward pec minor area. And it's a reasonable extrapolation that if the artery is compressed, the nerves are compressed. We should take a step back and say, why are we doing these orthopedic assessment tests to begin with? Why are we having a webinar on thoracic outlet syndrome? Well, as we said before, 90% of the time, there's going to be neural compression. And the majority of that time, it will be sensory neuron compression, which means the client will come in with some type of altered sensation, paresthesia, perhaps tingling numbness. And it's entirely possible that that could be interpreted as something like a compressed nerve at the cervical spine or carpal tunnel syndrome or something along that line. So it's very important for us to understand if they in fact have thoracic outlet syndrome. So most of the time we're looking for neural compression, and we will use the arterial compression as the vehicle toward the reasonable extrapolation that there's neural compression if the client came in with some type of numbness, tingling, pins and needles somewhere in their upper extremity. And certainly there can be the other symptoms, arterial and venous or motor dysfunction with thoracic outlet. But most often it will be paresthesia in the upper extremity. So for Adson's test, Eden's test, Wright's test, we will be using a baseline strength of pulse of the radial artery. We will then put him in a stress position that stresses either the scalenes, the costoclavicular space, or the pec minor. If we feel that the strength of the pulse decreases, then we have a positive orthopedic assessment test. And we know that the person has, whether it's mild, moderate, marked, or severe, depending on the decrease in the strength of the pulse, we have a positive orthopedic test for one or more versions of thoracic outlet syndrome. Now, I will also add, if he feels an increase in paresthesia in the upper extremity, that is also a positive. That's a subjective symptom positive based on how he reports. But the strength of the pulse decreasing is an objective sign. And generally speaking, when we're looking at assessments, generally speaking, an objective sign that the therapist can measure is more reliable than what the client reports, although we always want to know what they will report also, and we add that into our assessment picture. So, Adson's test for anterior scalene syndrome. So just relax, let me have the weight of your upper extremity. Usually if there's any music on in the background or whatever, for me, I always like to get rid of all other sensory stimuli. Some people it's really easy to find a pulse, some people it's very challenging. I very often close my eyes. I really want to be in my finger pads here. I really want to feel for that pulse. And once I get a good bead, a good baseline strength of pulse, now, Andrew, what I would like you to do is rotate your head and neck to the same side, to the right, as far as you comfortably can. Perfect. Staying rotated to the right, I would like you to drop your head and neck back on your left shoulder. Perfect. Stay there for a moment. Now he has right rotated, left laterally flexed, and extended. And I feel for the pulse strength. Does it change? If it stays the same, then we have a negative Adson's test. If it decreases, we have a positive Adson's test, and we know he has anterior scalene syndrome. You can relax, go to a comfortable, healthy posture. If you're not sure, you could repeat it. Very often when I get a positive, I will repeat it just for confirmation. One more time, rotate to the right as far as you comfortably can. Drop your head and neck back to the left. Feel for a change in the pulse or not. Back to neutral. That's Adson's test. Adson's test is for anterior scalene syndrome, but I will add that when the client does have a cervical rib, it will show positive with Adson's test because that cervical rib comes right between the anterior and middle scalenes, and we pull the scalenes taut against that cervical rib, and we have the neurovascular structures there. Now, let me make another mention on why we're going into this position. We have three cardinal plane components to this oblique plane position. The oblique plane position in the end is back there. What are the components? Well, one component was sagittal plane extension. Scalenes are flexors in the sagittal plane. This stretches them. Another component was frontal plane left lateral flexion. The right side scalenes are right lateral flexors. This position stretches them. The third component is transverse plane ipsilateral rotation, in this case, right rotation. Although the scalenes can be ipsilateral rotators. They are not ipsilateral rotators from anatomic position. They are much stronger at being contralateral rotators, which means the right anterior and middle scalenes are left rotators, which means they are better stretched with right rotation. This stress position, and that's what an orthopedic assessment test is. It is basically stress and assess. This position stretches the right side anterior and middle scalenes in all three cardinal planes. When you stretch a muscle, it gets pulled taut, it gets harder, and we would have that compression coming out on either the brachial plexus neural structures or subclavian artery. Or if he had a cervical rib, it would show there. By the way, a definitive diagnosis for cervical rib thoracic outlet syndrome would be with an X-ray. Okay, so that would have to be ordered by a physician. Now we go to costoclavicular syndrome. We're going to use Eden's test for this, also known as military brace position. Again, relax your upper extremity, let me have the weight there. I get a good baseline pulse here. There we go, I've got it right there. Now, what I want you to do, Andrew, staying face forward, is I want you to stick your chest out and your shoulder girdles back like you're standing in front of a commanding military officer, hence the name military brace position. What he does is he pushes his rib cage forward, which means the first rib goes against the clavicle anteriorly, but at the same time, he pulls the clavicle back against the first rib and he decreases the space, the costoclavicular space. And relax and go back to a neutral posture. If the pulse decreased in strength, positive Eden's test, positive for costoclavicular syndrome. If the pulse did not decrease in strength, negative, negative for costoclavicular syndrome. Same mechanics as Adson's test. Now we go to Wright's test for pectoralis minor syndrome. Now with Wright's test, I'm going to move the client, so we really have to make sure you're relaxed and let me have the weight of your upper extremity. I'm going to be moving your upper extremity. Just let me move you, okay, and just stay relaxed and passive, okay? So I begin again, getting the bead on the strength of the pulse. There are two versions to Wright's test, and I will show you each one then the next. So you're comfortable? I've got you. I'm going to bring you back, and what am I doing? I am bringing his shoulder girdle back into retraction and elevation, which will stretch out the pectoralis minor. I am pulling the pec minor taut against the rib cage, and because the arm is up in abduction, I also have the scapula in upward rotation, which further stretches the pec minor. That is one of the versions. The second version, again, stay relaxed. Now, if I were in this same posture of palpating the pulse this way, I want to show you that it's awkward for the therapist because this is the final position and this is uncomfortable for me. So for this version, I switch over to my other fingers here. Once I have that pulse, relax, let me move you. Then I bring him here. And what's happening here is we're pulling the neurovascular contents, tethering it around the pec minor, which pulls it hard against the pec minor. If the pec minor is tight, you would get compression there. So what we're looking to do in Wright's test in either version, and I prefer the first version, I think it's more sensitive, is we're looking to bring out that compression between the pec minor and the rib cage. So we can see that if we understand the underlying mechanics to why someone can get anterior scalene syndrome, tight scalenes, stress them. They're already contracted and pulled in, locked short. Let's at the same time create external tension and pull them long and make them even harder and tauter. Or costoclavicular syndrome, the costoclavicular space is too small. Let's maximize that and really pull the two bones against each other and bring that out more. Or stretch the pec minor back and or tether the neurovascular contents against the pec minor. For Wright's test, we are upping the ante, so to speak, on the underlying pathomechanics that causes anterior scalene costoclavicular pec minor syndrome. Now, I'd like to add one piece to this. You will see in some textbooks and articles that it's recommended that you ask the client at the same time that you do anterior scalene syndrome's Adson's test. So I'm going to get that baseline here, and I'm going to ask you to rotate to the right and drop your head and neck back to the left. And then the textbook or article says, have them take a deep breath in here. Take a deep breath in. Okay. And then palpate the pulse with that deep breath. You can relax. The reason that's recommended is taking a deep breath in. We'll ask the scalenes to contract as accessory muscles of inspiration, which while they're already tight, while they're already being stretched, we now ask them to contract toward their center even harder. It should increase the sensitivity of Adson's test. And from that point of view, that makes sense. You can even see textbooks that will say, with Eden's test, I have you here, chest out, shoulder girdles back, take a deep breath in. He takes a deep breath in, he lifts his first rib up toward the clavicle. Relax and be comfortable, which again will even further diminish the space, the costoclavicular space. So it increases the sensitivity of Eden's test. And Wright's test, relax, just stay there. And I go back here, take a deep breath in, and relax. And what happens there? Pec minor is a muscle of inspiration. It goes from ribs 3, 4, 5 up to a higher superior attachment, coracoid process of the scapula. A deep breath in would cause the pec minor to engage as a muscle of inspiration, accessory muscle of inspiration. It should increase the sensitivity also to Wright's test. So, a deep breath in held will increase the sensitivity to all three orthopedic assessment tests. But here's why I do not recommend that you do that, or at least not the first time through. You might be doing Adson's test. So let's do this again. I've got your pulse, rotate to the right, drop your head and neck back to the left, take a deep breath in. I get a decrease in the strength of the pulse. I assign that as a positive Adson's test, but in reality what happened was, you can relax now, his deep breath in either lifted the first rib up against the clavicle and created costoclavicular syndrome coming out, or engaged the pec minor and brought out pec minor syndrome, but I assign it as anterior scalene syndrome because it was during Adson's, and then I direct my treatment toward the wrong thoracic outlet syndrome. So the idea of an assessment test, as I said before, is stress and assess. And when you can further the stress, you get a better assessment, more sensitive. But the next most important thing for a really good orthopedic assessment test is that you try to isolate the structures that are stressed. If the position of an orthopedic assessment test stresses just one structure, whether it's scalenes or the space here or pec minor, then what you're going to find is it's very easy to assign which structure is unhealthy. You know the structure that's unhealthy, you know the mechanism of the problem, you know the condition, you know the target for your treatment. But when an orthopedic assessment test stresses multiple structures, you're now a little bit stuck not knowing which structure is the one that brought out the signs or symptoms that caused the positive. So for that reason, to me, you're better off trying to keep these Adson's, Edens, and Wrights as isolated from each other as possible. And at least the first time through, do not ask the client to take a deep breath in. Now, I spent a fair amount of time describing this and describing these tests because to me, what's more important than you memorizing how to do a test is to understand the fundamental mechanics, pathomechanics, musculoskeletal, neuro, myo, fascio-skeletal mechanics. If you understand what you're doing, you can critically think. If you can critically think, you can creatively apply. And that will make you a more competent, a much better clinical orthopedic manual therapist that will allow you to better help a client who comes in looking for you to remedy a specific musculoskeletal, or again, I could say neuro, myo, fascio-skeletal complaint. I don't want to leave fascia and nervous system out there. I only have one piece to add about orthopedic assessment. You will very often get a paradoxical finding when you do Wright's test, especially the first version of Wright's test. So I get the beat on the pulse, you can stay relaxed, and I bring him up and back like this. And I've said up to this point that what you're looking for in these tests is, does the pulse decrease or stay the same? If it decreases, we have a positive. If it stays the same, then we have a negative. But sometimes when you do Wright's test, after being up there for about a second or so, the pulse actually increases. And that should make no sense, right? Because if anything, we're putting pressure on that axillary artery that's running between pec minor and rib cage. And what I believe is the underlying mechanism here is when the nervous system senses that a body part is lifted higher, it knows that it's going to have to increase blood pressure to get the blood up against gravity into that body part. It's very similar to a client might be lying down, and when they first sit up, if they sit up too quickly, they might get a little bit lightheaded, dizzy, because they have what's called orthostatic hypotension. And a healthy person doesn't get that way because their nervous system immediately compensates for the fact that their head and upper trunk is now higher than their heart, so they increase blood pressure to compensate. Well, it's similar with the arm going up. When you find that occurring, what I recommend is that you really make sure you have a good palpation of that pulse. And what did you feel when you first brought them up, before there was that compensation by the nervous system? So these are Adson's test, Eden's test, and Wright's test, orthopedic assessment tests for the three different, or actually all four different thoracic outlet syndromes. Now, we're manual therapists, and actually the most important assessment tool for manual therapists is myofascial muscle palpation. So we can also confirm our findings of thoracic outlet syndrome by doing palpation of the associated musculature, whether it be scalenes for anterior scalene syndrome or pectoralis minor for pectoralis minor syndrome. I'm going to show a very effective and easy palpation technique for the pectoralis minor muscle. I'll show it with our client Andrew seated here because it's easier for you to see. You could just as easily do this with the client supine, which is more likely the position the client would be in when you're then looking to work the pec minor. But let's show it seated. So the first thing I'm going to do is I need my landmarks. I'm going to find the clavicle, the medial end of the clavicle, and I'm just going to keep going laterally until I feel the concavity at the lateral end of the clavicle. And then I drop immediately inferior, and I feel for a hard bone here. And that hard bone will be the coracoid process of the scapula. Quick note, warning here. On plastic skeletons, they put this little metal contraption in on the head of the humerus so you can rotate it around, but that holds the head of the humerus farther away from both the glenoid fossa as well as the coracoid process, and a lot of students, a lot of therapists get a mental image of the humerus being much farther away from the coracoid process than it really is, which gives them a challenge when they're looking to find the coracoid process. So here we have our coracoid process. Pec minor goes from there, usually to ribs 3, 4, 5. So I drop immediately inferior off of the coracoid process. I'm on skin, subcutaneous fascia, pec major usually, perhaps deltoid if I'm a little over here, but usually pec major, and then pec minor. Now I need him to engage the pec minor, but not engage the pec major. The best joint action of the pec minor to accomplish this is downward rotation of the scapula. But you cannot create an isolated rotation downward or upward of the scapula. You have to do it via something known as scapulohumeral rhythm. He moves the humerus in a position to then ask the nervous system to create the coupled joint action of, in this case, downward rotation of the scapula. When the humerus extends and or adducts, the scapula downwardly rotates. So, Andrew, I'm going to ask you to place your hand in the small of your back. He is now adducted in and he's extended, but right now he's relaxed. In a moment, I say, I want you to move your hand right away from the small of your back. Show me. Perfect. Relax for a second. So now I know he knows what he needs to do. So I'm on the pec minor here. Go ahead and do that again. I feel the pec minor engage. It pushes my fingers out. Relax for a second. Do it again, and you can see my fingers being pushed out. And now I strum perpendicularly across the pec minor. It runs that way, so I strum this way. Relax for a second. Always give them a break occasionally. Again, do that. I strum perpendicular, stay engaged, and I move a baby step, I strum perpendicular. I move a baby step, I strum perpendicular. Relax. Again, I strum perpendicular, I move a baby step until I feel it end on the third rib there, and relax. I could then go back to the coracoid process, drop off, and repeat that procedure going to the fourth rib and the fifth rib. I strongly recommend this palpation for pec minor. The only time this would not work is if their pec major is so tight at baseline tone you can't feel through it. But that's fairly rare. Many people recommend coming into the pec minor by going deep to pec major this way. Frankly, you can't get to all of pec minor that way, and it's very uncomfortable for the client, and you have to lead with your fingertips, which means your nails, even if they're very short, will probably start to become uncomfortable for the client at some point. So I strongly recommend what I just showed. I will just make a statement. If he's lying supine and he has his hand in the small of his back, he will be between his back and the table. Even though he has no room for a movement of excursion, of further extension of the humerus at the glenohumeral joint, the fact that he pushes down against the table will still make his nervous system order that coupled downward rotation engagement, which means pec minor engagement. Now let's demonstrate palpation assessment for the anterior and middle scalenes, again on the right side. So we have our client supine. I actually have her scooted to the right side of the table so I don't have to lean over when a little later on I'm going to scoot myself over to the right side. And I'll show palpation of the bellies, then I'll show the rib attachment palpation, then the cervical spine palpation. So to find the anterior middle scalenes, we need to find the lateral border of the clavicular head of the sternocleidomastoid, the SCM. So what I'd like you to do, London, is I'd like you to rotate your head and neck to the left, and immediately we see the sternal head, because that's the one that's more engaged with rotation. But I need to find the clavicular head. I know it's somewhere over here. To engage better that clavicular head, in this position, I want you to lift your head toward the ceiling. And now we can see the clavicular head here, and you can see me strumming perpendicularly across it, and I drop off to its lateral side. You can relax now, and I can put her in a neutral posture. When I drop right off the clavicular head of sternocleidomastoid, I am on anterior scalene, and I will strum perpendicular to it, like this. And I feel for a little gap here, a little sulcus, and that's the border between anterior scalene and middle scalene, which is right here. And I can do palpation assessment for the bellies of these muscles. One quick precaution here, and that is that the brachial plexus of nerves exits between the anterior middle scalene, so you will be over the brachial plexus nerves. So if they feel zingy little sensations shoot down their upper extremity, the odds are you're on a brachial plexus nerve or nerve root. Just move a millimeter or two over and you can go off of that nerve. Now, of course, if they feel a referral of something in the upper extremity, but you feel a trigger point there, then that's not the nerve, it's a trigger point. Of course, life is not always easy. Sometimes you're on a nerve which is over a trigger point, and then you need to differentially assess through those two possibilities. Now, if I want confirmation that I'm on the bellies of the anterior and middle scalenes, I would use the joint action of elevation of the first rib. So London, I want you to take a short, quick, deep little breath through your nose, but not through your mouth, but quick, wait a second, do a second, wait a second, do a third. Go ahead. Shorter and quicker, and even shorter and quicker. There we go. I felt the scalenes engage. One more time. Perfect. Right there. Now I want to get to the first rib attachment. To do that, I have to slacken the skin and subcutaneous fascia here. So I can slacken it by laterally flexing her to the same side and flexing her in the sagittal plane forward. Now it actually blocks my hand coming in unless I go underneath her head, and I can then rest her head on my forearm. Just relax there. And now if you see my fingers, you can see me, make sure you're nice and relaxed. I can just sink in deep to the clavicle and find the first rib attachment of anterior scalene and middle scalene right there. Now to get to the cervical spine attachments on the transverse processes, and anterior scalene goes from 3 to 6 and middle scalene from 2 to 7, which is most of the cervical spine. Then for me to come in, I have to come in at an angle and I have to go deep to SCM. So I have to slacken SCM, and for my body mechanics not to have my elbow out, I will scoot over to the side of the table. To slacken the right side SCM, I passively put her in the positions of the joint actions of the right SCM, which would be flexion of the lower and middle cervical spine, right lateral flexion, and left rotation. And now right now we can see that she's contracting. Relax, relax, relax. And I have my hand underneath her head, kind of like a tripod. And when you see her relax here, then we know that we've softened, slackened the SCM, and then I can just push in deep to the SCM and feel for the transverse processes, and then I know I'm on the attachments of really anterior scalene, except for 2 and 7, and then deeper in on middle scalene. So that's palpation assessment for the anterior and middle scalenes. So we now understand the pathomechanics of thoracic outlet syndrome, and we understand how to do orthopedic and palpation assessment so we have a target for our treatment. Very briefly, let me just emphasize that because thoracic outlet syndrome can cause paresthesia in the upper extremity, it is extremely important to have a good assessment, a differential assessment, which means that we need to assess for all the different conditions that could cause that paresthesia, because again, it could be carpal tunnel, it could be pronator teres syndrome, it could be a myofascial trigger point referral, it could be a herniated disc in the cervical spine, osteophyte in the cervical spine. If we don't understand this well, it's possible that the client might end up going for a cervical spine surgery or carpal tunnel surgery or unneeded physical therapy treatment that if we got rid of, if we eliminated the at least cause or partial cause from thoracic outlet syndrome, that they might be healthy enough. So a good differential assessment is so critically important. Now we know they have one of the thoracic outlet syndromes. Just briefly, we have 2 major manual therapy techniques: soft tissue manipulation, in other words massage, and stretching. So very briefly, let's just take a look. If it's anterior scalene syndrome, so I want you to rotate left, lift your head up toward the ceiling. I find the lateral border of SCM, drop off, relax. I now know where the scalenes are. I could do cross fiber massage, I could do longitudinal strokes, I could do circular strokes, I could do static compression, I could do any soft tissue manipulation strokes you think are appropriate. I very much like circular friction strokes, but that's just my preference. Now I could also work the musculature on slack. So I would bring her into a position, now relax, 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 and I can go in deeper. Whenever you slacken the musculature, you can penetrate in deeper. Or I could work her on stretch. And then you get a good stretch to the more superficial fibers combined with massage. So that's one way I could address soft tissue manipulation to the scalenes. Costoclavicular syndrome. I might want to work the myofascial tissue that is directly deep to the clavicle, between the clavicle and first rib. I like to sit at the head of the table and curl my finger tips, pads and tips around and work into this area, reaching in not just for the superficial fascia, but also for the subclavius muscle, which if it's tight and or inflamed or hypertrophied, might further decrease the size of the costoclavicular space. Be careful when you do it this way. You tend to lead with fingertips. They can be very pokey. You need very short and smooth nails. Now we go to pec minor. If I want to do massage to the pec minor, then I have to find that coracoid process, drop off, and now I'm on pec minor over here. I could do cross fiber, I could do longitudinal strokes, I could do circular strokes. If I wanted, I can do something called pin and stretch. Now for pin and stretch on a table, you need to bring the scapula off the side of the table. There is a way of playing a game with this. You could put some type of a bolster under her rib cage on the medial side of her scapula, and then the scapula falls around it into retraction, which would stretch the pec minor, but more efficient will be to bring her scapula off the side of the table. So, London, I need you to scoot over to the side of the table, and I want you to just come over and over. So once I have her scooted all the way to the side of the table such that I can feel the medial border of the scapula is clearing the table, and I make sure that her head and neck are comfortable, then once I have her in that position, I really want to make sure that the draping is tucked under her nice and firm, because I'm going to bring her arm up and back, and that might pull and expose breast tissue. So just be careful about that. So I bring her arm up and back to about 135 degrees approximately of abduction. And notice that I have her forearm flexed at the elbow joint, and I'm holding her so she's resting her forearm against my forearm. And the reason I do that is when I start to bring her arm now back into what's called horizontal extension here, she might feel a stretch and say, stop, I can't take any more stretch. I say, oh, you feeling it here? And she says, no, it hurts over here. And that means I'm stretching the biceps brachii and it's stopping the stretch. So I want to slacken the biceps brachii and knock it out of the stretch. Now I just want you to scoot even a little more over to the side. Now, this can be a bit challenging. If you have a table with a scoop contour design, it's much easier because the scapula can be in that scoop area. So now I can simply stretch her in this position. That's a beautiful stretch for pec minor, and I can play with the exact angle of the stretch. But I can also do pin and stretch. Now, I'm going to ask you to just rotate a little that way if you're comfortable. I could use finger pads, and I pin in on pec minor, and then I bring the scapula back toward retraction and elevation, and I focus the stretch between the pinned point here and the attachment that I moved. So I focus the stretch to the superior aspect of pec minor. I can use finger pads, I can use thumb pad. They're very specific, but they're also very pokey. If I can use a broader attachment, it's more powerful and more comfortable for the client. I could use the ulnar side of my hand, and this is why I asked her to rotate away. I don't want my elbow to contact her face. And I could go like this. I could use the base of the palm of my hand, but if it's a female client, especially a large-breasted female client, the extension of the hand at the wrist necessary to stay away from breast tissue might become uncomfortable for you. So go ahead there, and you can scoot back onto the table. So we can work the pec minor with massage, we can work it with stretch, we can work it with pin and stretch. We've demonstrated stretching of pec minor for pectoralis minor syndrome. Let's briefly demonstrate stretching of the right side anterior and middle scalenes for anterior scalene syndrome. The scalenes are flexors in the sagittal plane, so we would need to bring her into extension in the sagittal plane. If the client is supine, clearly then we need to have them scooted way up so their head is off the table and far enough up that their head does not hit the table, especially if there's any wood, plastic, metal, anything there. And while I'm setting this up, I usually let them rest on my hand, on my thigh, and I plantar flex my foot so I'm nice and comfortable here. Then, because the right side, that's where we're demonstrating, right side scalenes or right lateral flexors, in the frontal plane, I need left lateral flexion with the extension. And then because the anterior and middle scalenes are contralateral left rotators, I need to add in ipsilateral right rotation. So the full stretch protocol would be from anatomic position here, right rotation, ipsilateral rotation, left lateral flexion with extension right there. And the stretch should be experienced right over on the anterolateral neck on the right side where the scalenes are. Just a note, precaution about this. We would never do this stretching position, especially with elderly or even middle-aged clients, unless we have first done vertebral artery competency test. Now, just to briefly state this, vertebral artery competency test has the same positioning as ADSENS test. There's only two differences. One is we add in asking them to pick one point and focus on that point, and we make sure that their eyes stay focused, because if they don't, it means that there's an insufficiency of blood going to the cranial nerves that innervate the muscles of movement of the eyeball. So we look for that. And the second difference is that we're not looking for symptoms down the upper extremity. We're looking for neural symptoms like dizziness, lightheadedness, ringing in the ears, nausea along that line. If we have a negative to vertebral artery competency test, then we can carefully, slowly proceed with the stretch protocol for the scalenes. My name is Dr. Joe Muscolino, and I hope you've enjoyed this webinar on the pathomechanics and assessment of thoracic outlet syndrome. I have been teaching for 32 years in the world of massage, both in the United States and overseas. I'm the author of multiple textbooks, multiple articles. I also have DVDs out on this subject, and I have a full certification in clinical orthopedic manual therapy, and I have a video streaming subscription service wherein we address all of these fundamentals from anatomy, physiology, kinesiology, pathomechanics, assessment, treatment, and more for manual therapists especially, and also movement professionals. So again, thank you once again. It's my pleasure bringing you this webinar on thoracic outlet syndrome.